All right. 5, 4, 3, 2, 1.
Hello, everyone. Thank you for joining us today's webinar. My name is Mary Corey. I'm the Education Specialist for WorldLink Medical, and I'll be moderating today's event. I would like to mention a few quick items before we begin. First of all, please make note of the features available to you within your GoToWebinar internet browser. In the lower right-hand corner of your screen, you should see the chat box where you can enter your questions to Dr. Rouzier. They will be answered at the end of the presentation as time allows. This web conference is brought to you by WorldLink Medical. We provide evidence-based, CME accredited education in preventive medicine and age management with a focus in bioidentical hormones. Feel free to visit our website for additional information on course offerings and dates for 2017. Today's event is sponsored by an educational grant from MedQuest Pharmacy. We are grateful for their continued support in recognizing the importance of patient and prescriber education in the field of bioidentical hormone replacement therapy. They are true leaders in the industry, and we are proud to be supported by them. Dr. Neal Rouzier is a pioneer and recognized leader in bioidentical hormone replacement field, treating more than 3,000 patients almost since its inception in the early 1990s. With over 17 years of experience as an educator and practicing physician and 29 years of emergency medicine experience, he has dedicated his life's work to uncovering the medical literature that supports safe and effective protocols for personalized patient care. He lectures worldwide on the benefits of hormone replacement therapy. He is also the author of Natural Hormone Replacement for Men and Women, How to Achieve Healthy Aging. It's my privilege to welcome Dr. Neal Rouzier for today's webinar from his hometown in Palm Springs, California. Hello, Neal.
Hi, Mary. Thank you. Happy Valentine's Day to everyone. For those of you in the Northeast, I'm basking in about 80-degree temperature, sunshine, blue skies, not a cloud in the sky. So anyway, I hope that everyone back east survives today. I guess they're in for another heavy snowstorm. Well, I don't have any good news today. Unfortunately, this lecture is going to be full of bad news. But I think everyone needs to know and understand the bad news. I just received word from Jeff Bray that the FDA has stepped in and stopped the compounding of all compounded melatonin. They do not consider it a safe medication. There's no data or studies to show that it is safe, and as a result, they have nixed compounding pharmacies' ability to compound melatonin. It is still available over the counter. Well, if it's not safe for compounding, then how is it safe to be sold over the counter? It's available over the counter as 1, 3, and 5 milligram strengths, and until we get further instruction and until Jeff is able to figure out how to get around this or what to do about it, for all of you, you need to understand that the compounding pharmacies can no longer compound melatonin. That's great news. Secondly, I received note from a practitioner in Ohio, Rob, thanks for sending this, that the state of Ohio has declared that prescribers of compounded drugs or engage in the compounding of dangerous drugs, i.e. prescription drugs, must obtain a license as a terminal distributor of dangerous drugs. These are hormones. After April 1st, any facility possessing compounded drugs or engaging in compounding without being properly licensed as a terminal distributor will be in violation of Ohio law. So solo practitioners that dispense hormones out of their office need to get licensed. Otherwise, you cannot do that. In addition, HCG is considered a dangerous and controlled substance in the state of Ohio. And there's a big move to make all compounded hormones, even estrogen, progesterone, labeled as dangerous and controlled. That's more good news. So I sent this out to a couple of practitioners, and I basically said that we're in a war and we don't realize the war that we're in. Nevertheless, the war is real. It's a dangerous time for all of us that want to prescribe BHRT. And unfortunately, as Lowell says, it's difficult to learn the truth about really what's happening to us, and this is basically governmental control. It might not be too late for all of us if we can get enough docs to wake up. Of course, it's not easy with a population that's kept fat, fatigued, forgetful, and confused about right from wrong. And I can see this happening more and more, more government control, more control over compounding pharmacies, more control over physicians that prescribe compounded hormones. It's really a very serious problem. The body has a deficiency and is crying out for hormones that can be labeled as dangerous poison, but yet the government says that it's okay to inject a toxin into the body like mercury, but it's absolutely dangerous to prescribe or take bioidentical hormones. This is all intentional. It's governmental control. Neal, you've been brilliant in bringing us the truth about and science about hormones. Maybe it's time to inject politics into your teaching. So I guess today is going to be about politics and what's happening. Thank you, Lowell, for your comments. And what I want to do today is to review a lawsuit that is actually online. That is the lawsuit against AbbVie and Abbott Laboratories, makers of AndroGel. And I want you to see and understand what's happening to the industry, what's happening to companies that are developing and marketing testosterone, as well as what's eventually probably going to happen to physicians that compound. So I don't want to scare everyone away from prescribing hormones, but I want you to understand what's going on. And if you understand what's going on, then you can better get an idea as to how to protect yourself and your patients, because there is a war. It's only going to get worse. So I'm going to review this case, and I'm going to shoot holes in this case, and I think that everyone needs to understand the truth about the case and the truth about the medical literature, but also understand where this case is going and what the experts believe and are now claiming and how to get around that. It's unfortunate that the experts, I will call them the plaintiff's experts in this case, truly do not understand testosterone, and they don't understand the complexity of it, and they really don't understand the literature. And hopefully, by the end of this lecture, you'll be able to further understand the complexity of prescribing testosterone and how to address those issues. So, let's move on. The defendants, which are AbbVie and the pharmaceutical industry, misrepresented that AndroGel is a safe and effective treatment for hypogonadism, and a condition that they referred to as low testosterone, when in fact the drug causes serious medical problems, wasn't aware of that, including life-threatening cardiac events, strokes, and thromboembolic events. I completely disagree with that, and they will, in this lawsuit, give reason why they make that claim, and I will give reason as to why that claim is completely and truly false. This is going to be a three-part webinar. Today is going to be a discussion of this case with my comments. The second webinar is going to be a different case with an introduction of the medical literature to disprove what I've listed in these two cases. And then the third webinar will be complete review of the medical literature that supports that testosterone is extremely safe and beneficial. And not only is it not safe, but it's probably harmful if you don't take testosterone, which is the harm of these cases in that practitioners will not prescribe it and patients will not take it out of fear of harm, when in reality, that is really what's going to cause harm by not taking the testosterone, which has been shown time and time again to protect against cardiovascular disease. There was an article that just came out recently. Actually, I got it yesterday. I can't remember the journal in which it was published, but it was another review article from the folks back east from Harvard, where they looked at this large group of men that had been prescribed testosterone over 5 or 6 years, and basically there were 2 deaths in the testosterone group that were not cardiac related, and I think there were 20 or 25 deaths in the placebo group that were all cardiac related, which proves that testosterone is very protective. It's not harmful. But they will make these claims that testosterone is harmful and cause life-threatening cardiac events, strokes, and thromboembolic events. Testosterone significantly increases platelet aggregation. Key emphasis on the word significantly. There was one study that showed that injectable testosterone increased platelet aggregation because of the effect on plasminogen, tissue plasminogen activator inhibitor. However, when you look at the outcome study of that, testosterone was actually protective. So even though it increases platelet aggregation, it does not prove that it increases heart attacks or strokes. But what they'll do is they'll take this, it increases platelet aggregation, and therefore we extrapolate that it could cause harm. Now, you can't extrapolate and you cannot assume. You have to prove it and show it. And when that study shows that it does not, and all the outcome studies show that you don't, and all the outcome studies show protection, you cannot make that assumption, that extrapolation, but they do. In addition, which is my big complaint about this whole entire industry, is that it causes an increase in hematocrit and estradiol in adult males, resulting in thick blood, development of blood clots, and heart damage. For those of you that have not taken the WorldLink courses, you may not understand that, because testosterone does cause an increase in hematocrit, which some people term thick blood, and thick blood causes strokes and heart attacks. Again, what they've done is they've made an assumption and a jump and an extrapolation that the increase in hematocrit via testosterone causes thick blood and blood clots. There was no study in 50 years that shows that testosterone, which increases hemoglobin hematocrit, increases blood clots, heart attacks, or strokes. All the literature shows protection, except for those two flawed studies, the vegan and the Finkel study, and that's what everyone wants to hang their hat on, two extremely flawed studies that should be discarded and should be retracted. But everyone wants to hang their hat on those two studies. But those two studies do not negate 50 years of positive studies. And of course, this most recent study is just one in many studies that show that testosterone does not only not cause blood clots, heart attacks, or strokes, but is actually protective against them. These effects, if not monitored and controlled properly, can lead to life-threatening cardiac events. Also, it increases estradiol in adult males. And they're making claim that AbbVie and Abbott do not advise doctors of the increase in hematocrit and the need to monitor it, control it, and that they do not advise of the increase in estradiol, which they extrapolate causes an increase in heart attacks and strokes. I will show you how harmful estradiol is, and then I will show you how protective estradiol is. Unfortunately, you need to understand, as we've taught in the WorldLink courses, observation does not prove causation. And then what they're taking is a pure observation that high estradiol levels is associated with an increase in heart attacks. It absolutely is in every study. High estradiol in both men as well as in women, high estradiol increases the risk of heart attacks and strokes. That doesn't mean it causes it. It shows that it's an association. Of course, increase in visceral fat, as we all know, increases production of estradiol. What makes you think it's the estradiol that's causing the heart attacks and strokes? Well, because it's elevated. Well, so is the cholesterol. So are the lipoproteins, the harmful ones. So are the fatty acid esters. All of those other factors are elevated, and so is your visceral fat. What makes you think it's not the visceral fat and the dyslipidemia that's causing the heart damage? Well, because the estradiol level was elevated. Well, so is the cholesterol. What makes you ignore the fact that the cholesterol is elevated and point your finger at the estradiol? The reason they do it is because they can. However, when you do interventional studies and you see what happens when you raise estradiol, there's 50 years of studies where we raise estradiol. Every time you give testosterone, it raises estradiol. There's 50 years of studies, hundreds of studies, showing that raising estradiol is actually protective and beneficial. What they've done is they've taken an observation and extrapolated it to, well, if we observe it as high and then we cause it to be high, it's going to cause problems. Well, you've got to prove that with outcome studies. What outcome study, please don't mention the Finkel or the vegan study, what outcome study, what randomized controlled trial, what meta-analysis showed increase in harm? Not a one. Which randomized controlled trial showed benefit? Almost all of them. So what they're doing is they're taking a baseline observation and extrapolating it to harm, whereas when you study it with an outcome study and you raise estradiol by giving testosterone, there is no harm, there's protection. For those of you that have taken the courses in Part 3 and Part 4, we also look at what happens when you give estradiol to men. Why would you give estradiol to men? For prostate cancer. There's a multitude of studies out there showing when you give estradiol to men, it's beneficial. When you use Casodex and Lupron, the LH-RH antagonist, it kills men. It increases the risk of heart disease, plaque deposition, and heart attacks in every study. And when we look at those studies in those individuals that were on Casodex and Lupron and we gave them estradiol, it eliminates all of the harmful effects of Casodex and Lupron and actually provides cardiac protection. It reverses the dyslipidemia that you get when you block estrogen. Every study when you block estrogen has been shown to be harmful, but everyone wants to block estrogen, and their claim in this paper is that you need to block it. You need to measure it and then block it. They don't give you numbers with which you need to use. They just say it causes harm and no one addresses it, and the doctors were not taught and told that it causes harm. I find no study when we give estrogen to men that it causes harm. There's one exception to that when you give high-dose DES, that's 5 milligrams. Well, no one gives DES anymore. We give just estradiol, and there's no study showing harm of estradiol. But in every study, when we give estradiol and raise estradiol levels, there's a beneficial effect. So there's a direct effect on blood vessels, lipids, dyslipidemia, etc. when we raise estradiol or if we give estradiol to men. Just the opposite of what they are claiming. And of course, those of you that have taken the Part 3 and Part 4 know that I reviewed, there's probably 20 studies out there that show that when you block estradiol, when you block aromatization of testosterone into estradiol, it portends harm. Two most recent studies show, there was a real nice study recently, that showed that when you block estradiol, it adversely affects libido and orgasmic function. Strength of orgasm is completely related to estradiol levels. And when you block that, you block orgasmic ability and intensity of orgasm. And of course, the article from the New England Journal of Medicine showed that when you block estradiol with Arimidex, you increase visceral fat, you increase subcutaneous fat, you increase cholesterol, you lower HDL cholesterol, you increase triglycerides, and you increase harm. So in spite of the fact that that's what they claim, that's not what we see as evidence. Unfortunately, I'm not involved in defending this case, and from what I've seen and heard from the experts that are academicians, they have no idea on how to defend high estradiol levels, and they have absolutely no idea how to defend high hematocrit. For those of you that want, before we get to the lecture later on in the webinar series, want to go back and look at polycythemia versus erythrocytosis, you can go to YouTube, plug in my name, go to the YouTube video on erythrocytosis versus polycythemia, and you will see how in all of these studies, erythrocytosis is not harmful. Polycythemia is. And when you see these studies that say high hematocrit is associated with an increased risk, that high hematocrit is with polycythemia. Polycythemia vera with increased platelets and WBCs. Erythrocytosis in itself does not. All those people that live at altitude, there's 500 million around the world that live at altitude and have a high hematocrit and hemoglobin. Do they have an increased risk of heart attacks or strokes? Absolutely not. Do we tell them they got to move to the sea level? Absolutely not. Is there any harm in living at altitude and having a high hemoglobin hematocrit? Absolutely not. Then why do we extrapolate it? Well, because high hematocrit has been associated, that's polycythemia. It's not erythrocytosis, it's physiologic. And there's that landmark article that was published in the Asian Journal of Andrology that showed that the mechanism by which hemoglobin and hematocrit is increased at altitude is through the increased production of DHEA and testosterone, which stimulates the red cell progenitor cells. So the mechanism of increase in hemoglobin at altitude is identical to the same mechanism by which we see erythrocytosis by taking testosterone. The mechanism is identically the same. I remember in court, I was able to have the defense attorney ask the plaintiff's expert on what the mechanism of erythrocytosis at altitude was versus that of giving testosterone. He says, it's completely different. It's completely the opposite. There's no comparison. The mechanism is completely different. And then we showed him this article that's showing that the mechanism was the same. And he was just completely discredited. And of course, they lost the case. Anyway, these effects, if not monitored and controlled properly, can lead to life-threatening cardiac events, strokes, and thromboembolic events, including but not limited to DVTs, pulmonary emboli, transient ischemic attacks, strokes, and numerous types of cardiovascular injuries. That's completely false. But their claims, again, are increase in hematocrit from polycythemia, it doesn't cause polycythemia, and increase in estradiol, which, yes, it does cause an increase in estradiol, but that estradiol is not harmful at all. It's harmful when you block it, and they're claiming, no, it's harmful when you raise it. Unfortunately, the experts that are the plaintiff's experts in this case do not understand. I would love to get them in court and testify against them and show them, as I have in other cases, that what they make claim to is completely false. The defendants, these drug companies, fail to adequately warn physicians about the risk associated with AndroGel and the monitoring required to ensure their patient safety. And the monitoring is for increase in hematocrit and hemoglobin and an increase in estradiol. This is cute. Defendants, the drug companies, engage in aggressive and award-winning direct consumer and physician marketing. Boy, that's nice. And advertising campaigns for AndroGel. Defendants engage in an aggressive, unbranded disease awareness. They created a disease. They created an illness of hypogonadism. And this unbranded disease campaign alerted men that they might be suffering from low T, an abbreviated form of low testosterone. And they're claiming that this was disease mongering. There was no disease or illness there, but they made it. Additionally, low testosterone is not a disease recognized by the medical community. That's like saying, well, low estrogen is not recognized by the medical community. Well, it's called menopause. It is recognized. Low testosterone is not recognized by the medical community? Really? What about all the medical literature that shows that it's harmful and all the medical literature that shows that it's beneficial? Again, completely a false statement. Instead, it's the result of normal aging process experienced by males. Well, of course it's a normal result of aging process. So is menopause. So is andropause. So is loss of all the other hormones that we see as we age. It is a result of the normal aging process, and it results in all circumstances an increase in disease and illness. So what they may claim to, entirely false. As a result of this disease mongering, diagnoses of low testosterone have increased exponentially. This is directly related to AndroGel sales of increasing to over 1.3. Originally it was 1 million. Now it's 1.3 billion per year. A tremendous profit that they're, again, trying to claim that because of this disease mongering, these drug companies were able to benefit. Consumers of AndroGel and the physicians relied on the company's false representations and were misled as to the drug's safety and efficacy. And as a result, they suffered injuries including life-threatening cardiac events, strokes, and thromboembolic event. In this one case here, there was a gentleman who suffered a stroke, a heart attack, and a DVT and a PE. And they're claiming that it was all due to testosterone. And if he was aware of the life-threatening cardiac event of heart attack, stroke, and PE, that he never would have taken testosterone. But the physician prescribed it because we were not made aware of the harmful effects of it. Defendants' wrongful acts, omissions, and fraudulent misrepresentations caused the plaintiff's injuries and damage. Unfortunately, I've had to defend a couple lawsuits where the plaintiff's attorneys claim the same thing for their clients that unfortunately suffered PEs or heart attacks. Fortunately, I was able to prove to the jury that testosterone does not cause those problems, and I used all the medical literature and the science to support protection against heart attack, strokes, and there was no increase in DVT or PEs based on the literature. Unfortunately, I will mention the articles by Dr. Glueck. He's published a couple articles in medical journals claiming that testosterone increases the risk of DVT and PE in patients with factor V Leiden. If you look at all the world's literature and you look at all the randomized controlled trials, there's no study to show an increase in PE or DVTs in the general public, and that includes patients with thrombophilias. But what Dr. Glueck did was he looked at a list of patients that had factor V Leiden, and he sort of handpicked those that were on testosterone and showed that, indeed, those people with factor V Leiden did indeed get DVTs when they took testosterone. He reported it to the FDA. He also published it. Once the FDA is notified of a potential risk or side effect, they are obliged to report it. If they do not report it and they hide it, then they're at what's the word I'm looking for? At fault. And as a result, any side effect in any study or any side effect reported to the FDA, even though it's one person out of millions, if they got a side effect and report it to the FDA is obliged to report it, which is why there's 4 pages of side effects with testosterone that have been reported. Nevertheless, there's no study to show an increased risk of DVTs. In fact, most studies show an actual decrease in DVTs and PEs. But because it says it in the PDR, the reason it says it in the PDR is because Glueck reported it to the FDA. The FDA now reports it, and then plaintiff's attorneys will then say, see, it says right here in the PDR that testosterone may, it doesn't say it does, may does not mean does, may cause an increase in blood clots or DVTs. So now the FDA is covered, they reported it, but then plaintiff's attorneys now want to make that claim, even though there was no study. Well, I explain to the juries why it says it in there. There is no study, randomized controlled trial that shows that, only a report. That report from Glueck has been discredited and stated to be flawed by many researchers. In addition, I have probably a dozen patients in my practice over the years that have had factor V Leiden and have taken testosterone. None of them have developed a DVT. Most of them are not on Coumadin either. So if I publish a study that said that I've got a dozen patients with factor V Leiden that are on testosterone and have not had DVTs, I could then claim that testosterone protects against DVTs, just as Glueck states that, no, it causes it. Well, his is an observation. Mine is an observation. Both observations prove different things, which is unfortunately why observational studies are so weak and really should not be relied upon. They're interesting, but they don't prove anything. Observation does not prove causation. He cannot prove that taking testosterone caused the blood clots in patients with factor V Leiden, although he makes those claims. I cannot claim that testosterone protects against DVTs and PEs, even though that's what I observed. But I can't make that claim either. It's an observation, and it does not prove benefit or causation. So in spite of the fact that the PDR states that, in spite of the fact that Dr. Glueck claims that, there is no study to show it. You need an outcome study that looks at it and factors in all of those biases. There's no study that shows harm, only in Glueck studies. The plaintiff was prevented from discovering this information sooner because defendants herein misrepresented and continue to misrepresent the public and the medical profession that the drug AndroGel is safe and free of serious side effects. Defendants have fraudulently concealed facts and information that could have led plaintiff to discover a potential cause of action. Well, this is fine and dandy, and you can make claim that the defendants are responsible for hiding that information from physicians, although there was really no information to hide. You can see how this may apply to doctors that are prescribing compounded testosterone, which is how this applies to all of you that continue to prescribe it. You're concealing facts and information that could have led the plaintiff to discover a potential cause of action. Well, as a result of this, I've had a couple of attorneys say their doctors, the treating doctors, did not warn the patients of the potential risk. So as a result of this, I am recommending that every patient that you now treat, that you have in your consent form, and I actually document this in my note, that you advise the patient of the possible and may cause heart attack, strokes, and DVTs. You don't feel that there's any literature to support it. That's what I put. I do not feel that there's any paper or outcome study but because it says it in the PDR that we are advising the patient that it states that in the PDR. We do not feel that it's harmful. We would not give something that we would feel is harmful. But because it says it in the PDR, and because plaintiff's attorneys are now claiming you didn't warn the patient, therefore I would add, patient is advised of the risk of heart attacks, strokes, and DVTs. I also put in there that we do not feel that this is a true statement, but because it says it in the PDR, we are advising the patient. We're not hiding anything, we're not misrepresenting, and we're not hiding anything from the patient. We're advising them. We are warning them of what the warning states. Then you're covered. The average testosterone level for most men ranges from 300 to 1,000. However, testosterone levels can fluctuate greatly depending on many factors, including sleep, time of day, medication, etc. Resultantly, many men may have testosterone levels below 300 on one day and will have normal testosterone levels on the next. This decline in serum testosterone levels is a normal process and does not represent a medical condition or disease. I completely disagree with that, and the medical literature supports that. But what they're trying to do is claim that this patient, as of all patients, did not have a level less than 300. And as a result of not having a level less than 300, they did not qualify for treatment. That is the severe criticism of the recent AACE guidelines, and the AACE guidelines were developed because the FDA told them to put it in their guidelines, that in order to diagnose a condition called hypogonadism, your level has to be less than 300 on 2 separate days. If your level is 290 on one day and 301 on the next day, then you do not qualify for treatment, and you do not have, by definition, hypogonadism. Well, the FDA has now said that, or stated that, testosterone is only FDA approved for treating hypogonadism that is related to a medical condition. And that medical condition could be irradiation, cancer, or some sort of pituitary dysfunction or problem with the gonads that is congenital. So they've severely restricted the definition of hypogonadism, and they've severely restricted the number that will qualify for most patients to be prescribed it. And as a result, I do not diagnose or claim hypogonadism because they have normal testosterone levels. Well, 95% of the men that are presently taking testosterone and for which it is prescribed have normal testosterone levels. Therefore, they do not qualify for it based on the diagnosis of hypogonadism. I absolutely agree. They do not have hypogonadism, and I don't prescribe it for hypogonadism, but it doesn't mean that you cannot prescribe it. It is perfectly legal for any doctor to prescribe any medicine for off-label use. The label use is you have to have hypogonadism with 2 levels less than 300 and symptoms and signs of a deficiency. Then you have hypogonadism. I'm not treating hypogonadism. I'm using it off-label to treat other symptoms, to make the patient feel better. I'm treating symptoms, not hypogonadism. It is perfectly legal to do so. Of course, the FDA doesn't want you to know that, but it is perfectly legal to prescribe any medicine off-label. 50% of the medicines that we prescribe for our patients are for off-label use. They have one label of indication. But that does not mean you cannot prescribe it for other reasons, but you need to document why. What is the reason that you're using it and prescribing it? What is your symptom? As long as you document the symptom and the reason that you can prescribe it, it is perfectly legal to prescribe it. They have tried to paint me in a corner that we diagnosed it for a off-label use. Well, of course I prescribed it for an off-label use. Well, you cannot. Where does it say it cannot? It says it in the guidelines that you cannot prescribe testosterone. It doesn't say that. I have told them, go read what the guidelines state. And they say, no, the guidelines state that you cannot. So I caught them in court, and I said, that's not what the guidelines say. You guys are lying. Oh, no, we're not lying. This is what the guidelines state. So what do? I pull out the guidelines. and I read from the guidelines. The guidelines state, we suggest, we recommend. It doesn't say cannot. It says we suggest. Go read the guidelines. The guidelines specifically state it's a guideline. It's a suggestion. We suggest, we recommend. It does not say cannot. It does not say you cannot use it for off-label use. It says we suggest. These last two cases were easy to win based on the fact that I showed that what the plaintiff's experts were claiming was completely false and wrong. And as a result, it was sort of fun. But it's not fun for you because you need to know and understand the literature. You need to understand the guidelines. You need to understand why and how to prescribe it and what to document. Despite this admonition from the FDA, the defendants continue to market and promote testosterone replacement for andropause and low T. Well, that's sort of where they're going to get caught because the FDA has made testosterone FDA approved for treating hypogonadism with levels less than 300. Unfortunately, the companies marketed it and promoted testosterone for andropause and for symptoms. You cannot and should not market any drug, any medication for something other than the FDA-approved indication. So this is where a lot of people are getting in trouble with the FDA and the medical boards and in their literature that they write in their websites and their advertisement. I hate to tell everyone this, but you need to go back and look at your advertisement. If you make claims that testosterone does this, improves libido, sexual function, orgasm, strength, energy, muscle mass, you need to erase that. Testosterone is only FDA approved to treat hypogonadism, period. That is all that you can say. You can state what low testosterone causes. You can state that it causes loss of libido, sexual function, orgasmic ability, strength, energy, muscle mass, and that low levels have been associated with increased risk of heart attacks, dyslipidemia, etc. You can state that. And that testosterone treats or reverses that. You can only state that testosterone is FDA approved to treat hypogonadism, period. And if you want to say what hypogonadism is, you can, but most people will fall outside those guidelines, and you cannot advertise that you treat that. You can treat it. You can discuss it in person. You can hand out that literature once you've discussed it with the patient in your office, but you cannot advertise it or market it as such. Defendants coordinated a massive advertising campaign targeted towards men who do not have hypogonadism, nor have low or no testosterone, in conjunction with an associated medical condition. Again, hypogonadism, levels less than 300 on two separate occasions, and in conjunction with a medical condition that results in low testosterone. The direct-to-consumer marketing was designed to convince men that they suffered from a non-existent and unrecognized medical condition called low T. Well, men suffer from loss of libido and sexual function. But that, according to them, doesn't fall under the category of low T. Defendants orchestrated a national disease awareness media blitz that purported to educate male consumers about the signs of low testosterone. The marketing campaign consisted of television advertisement, promotional literature, placed in healthcare provided offices, and distributed to potential AndroGel users, and online media, including the unbranded website, Is It Low T? So you can see how AbbVie and Abbott are going to have to own up to the fact that they did advertise and market for signs and symptoms beyond what it was FDA approved for. They can't do it. You can't do it. You should not do it either. But what you can market is that you treat with testosterone to help improve symptoms of patients, but you can't state what those symptoms are or what the cure is. The defendants manufactured, sold, and promoted the drug to treat non-existent medical condition that it called low testosterone or low T, which has a name it created for the constellation of symptoms experienced by men as a result of the normal aging process. In essence, the defendants marketed and sold testosterone as a lifestyle drug meant to make men feel better. Well, it does make men feel better in every study, and increase libido, which it does in almost every study. There's one study that showed that it didn't increase libido, and that was the one recently published in JAMA. And the levels of testosterone went from 300 to 400, and they showed improved that it did not improve libido or sexual function. Well, of course it didn't. The levels were not high enough. The conclusion from the authors was, you don't need to use testosterone, it does not work. Yeah, but what about the other 1,000 studies to show that it does? Well, our study negated all those other 1,000 studies. No, your study does not negate those other 1,000 studies. But you can see the pushback. You can see the war against the use of testosterone. And the war is from the FDA. The war is from zealots. The war is from an industry that just does not like you prescribing it. And on a daily basis, I get pushback. Patients will call me and state, my doctor told me to stop the testosterone. It causes heart attacks, strokes, and blood clots. No, it doesn't. Well, my doctor scared me, so I'm going to stop it. And when the patient stops it, they all call back and say, I feel like crap, I want to go back on it. Yeah, but what about the heart attack and stroke? I'm sorry, there is no evidence for that other than what they say. Are they lying? Yeah, unfortunately they are. But they're extrapolating 2 studies to prove and show harm, and they really shouldn't do that. Defendants successfully created a robust and previously non-existent market for their drug, testosterone. The company also spent millions on its unbranded marketing, including commercials and websites. Take this as a red flag. You too should not market in your website testosterone, doing all those things that you claim. You can state what it is FDA approved for. You can state what happens when you lose it, but you cannot make claims of what it does and that it makes patients feel better and function better. It's not FDA approved for that. Low T as a template on how to sell disease. Whether the campaign is motivated by a sincere desire to help men or simply by greed, we should recognize that for what it is, a mass, uncontrolled experiment that invites men to expose themselves to the harms of a treatment unlikely to fix problems that may be wholly unrelated to testosterone levels. Really? Unlikely to fix the problems? Where does it say that? Well, there's one study, yeah, but what about the other thousands of studies that show that it did fix it? We'll ignore those studies. You can see where this is going. We agree with Braun that there's a strong analogy between the marketed testosterone therapy for men and estrogen therapy for menopausal women. Ignoring the lessons of estrogen therapy is scandalous. Ignoring the lessons of estrogen therapy? Yes, estrogen is extremely harmful and bad. That's why we shouldn't prescribe it. What study showed that estradiol was harmful? None. Yeah, but Premarin, well, don't extrapolate the harm of Premarin to estradiol. Well, they're the same. If you think that Premarin is the same as estradiol, this conversation cannot go on. But you can see how they will make this claim. We know how bad estrogen is, and as a result, we also know how bad testosterone is. This is a war, and it's very unfortunate. Defendants' advertising paid off in a return of $1.4 billion in sales during 2013, and are expected to triple to $5 billion by 2017. In 2009, a whistleblower lawsuit was filed by Relator John King and Jane Doe on behalf of the United States, and 23 individual states alleged that AndroGel was marketed and promoted for off-label use, which it was. Should we hide that from men? Well, I don't think that we should hide it, but you have to understand where they're coming from, that it was promoted for off-label use, and the law states you cannot promote it for off-label use. If they can't do it, you cannot do it, you should not do it, including osteoporosis, sexual dysfunction, depression, and obesity. Well, then how are the patients supposed to find out that it helps to improve those symptoms and those problems? They can't until they come to you and you can mention it to them and talk with them about it. But you cannot market it to the public. That's law. They can't. You can't. I suggest that you don't. The marketing program sought to create the image and belief by consumers that physicians that low testosterone was an actual disease or medical condition that affected a large number of men in the United States. I've been guilty of that. I did the same thing. I mean, how many thousands of patients have I helped by treating them with testosterone? And I marketed to them that what they had could cause a disease, heart disease, strokes, and that the medical condition that they had, low testosterone, adversely affected their health and wellness, and they improve and feel much better on it. I'm guilty of it too. But I guess what I then can advise you to do, don't be guilty of marketing. At all times, material hereto defendant's marketing strategy included the use of or sales of drug detailing representatives, in some situations liaisons, and marketing and brand team personnel who performed online and in-person AndroGel product detailing to physicians, and promotional and detailing to healthcare providers and physicians at medical organizations and societies. So their marketers, their drug reps, marketed AndroGel to physicians as a treatment that all men should need and utilize, and they used the medical studies to support why they do what they do. Defendants' drug reps detailed and marketed AndroGel to physicians as a product approved and indicating for the treatment of age-related declines in testosterone levels and age-related symptoms. It's not. It's not FDA approved for that. Back in 1999, it was. Back in 1999, the FDA approved testosterone to treat symptoms of hypogonadism and andropause. There was no number that was associated with andropause. There was no biological parameter that denoted a deficiency. Back then, it was symptoms. But since then, the FDA has changed for what it is approved for. And as a result, they've severely restricted what it is FDA approved for. That basically means that you can't get insurance to cover it. And what that means is that when you prescribe it, you're prescribing it off-label, and you need to advise the patient and document that you have. Defendants marketed, promoted, and detailed AndroGel for off-label use for the purpose of label expansion. So, see, yes, they did market it for off-label use, but it doesn't mean that you cannot use it for off-label use. It just says that you cannot market it for off-label use and promote the product to patients or physicians as such. A manufacturer may not introduce a drug into interstate commerce with an intent that it be used for off-label purpose. You cannot market it as such. It doesn't mean that you can't use it. It just says that you can't market it as such. But you certainly can utilize it. You just need to document why you're using it for off-label use, because the patient didn't qualify for it. Well, what do? You let the patient suffer with the symptoms? Do you let them live like this forever because they don't qualify based on the diagnosis? No, you can still treat them. I will go through that in the third webinar of all the literature that supports treating patients with an off-label purpose to help improve how they feel and how they function. It's healthy and beneficial. A manufacturer misbrands a drug if the labeling or any of the manufacturer's promotional or advertising materials describe an intended use for the drug that has not been approved by the FDA. If the drug companies can't do it, you can't do it. You need to go back and look at your marketing material. You need to look at what you send, and you need to look at what's on your websites. Promotional materials are misleading if they suggest that a drug is useful in the treatment of a broader range of conditions. I have looked at many people's websites, including my own. Every website that I've looked at is guilty of misleading and recommending that we use testosterone for an off-label use and for an off-label FDA-approved indication. So my suggestion is you go back and look at it and you put exactly what it's approved for, and that you state that you can prescribe testosterone, and you prescribe testosterone for hypogonadism. You can state that. The patient will not have hypogonadism, but you can state that you only use testosterone for treating hypogonadism. The patient will not know the difference. They'll say, okay, this doctor prescribes testosterone, great, and he uses it for hypogonadism, even though the patient does not fall into that category. But my suggestion is that you advertise that you only use it and treat for the FDA-approved condition, which is hypogonadism. The FDA did not and never has approved AndroGel or testosterone for age-related decline, age-related symptoms, mood disorders, depression, lack of sexual interest, libido, sexual function, disorders of erectile dysfunction, loss of muscle mass, strength, or energy, or bone loss or osteoporosis. Even though it helps all those things, you cannot make claims that it does. You can tell the patient that it does, but you cannot market it as such. I addressed this earlier, but I will just briefly talk about it again. When a person's hematocrit is raised through erythrocytosis, the resulting condition is called polycythemia, which simply means an elevated red blood cell count. No, poly is multiple. Cythemia is increase in cell count. Poly, multiple cells with increased cell count, is white cells, red blood cells, and platelets. That's polycythemia vera. It is diagnosed with a JAK2 gene blood test and high white cells, red cells, and platelets. It's the high platelet count and some other adverse effects of platelets on the blood vessel wall that cause blood clots. But we all think that it's an increase in red blood cells that's causing it because it's increased, and because we monitor and adjust phlebotomies based on red blood cell count, and because we think red cell count causes thick blood, that we blame the high red blood cell that's causing the harm. But there's 500 million people that live at altitude that have high red blood cell counts, and they don't have an increased risk of heart attack, strokes, DVTs, or PEs. We don't phlebotomize them. There's no treatment, and there's no workup necessary for those people. Well, the experts will claim, well, testosterone raises it and causes polycythemia and causes blood clots by a different mechanism. No, it's the same identical mechanism. We don't treat people at altitude. You do not need to treat people that have physiologic erythrocytosis. Unfortunately, you need to treat these people. Why? Because everyone out there thinks that it's polycythemia. Every cardiologist and PMD out there thinks that it's polycythemia. And no matter how much you argue and say no, that they're wrong, they will insist no, that you're wrong. Whenever I encounter a patient who comes back and says, doctor says, then I will tell that patient, do what your doctor says, go get phlebotomized. The problem is when you get phlebotomized, you become iron deficient, and then you get fatigue. Nevertheless, it's extremely important that you understand and know and realize this, because if you don't, then you're going to get into problems and trouble because the PMD and the cardiologist are going to say that you don't know what you're talking about. And as a result, I encourage you, if push comes to shove, just send them to get phlebotomized. Problem solved. It's an easy solution. This is a serious medical condition that requires treatment to prevent injury. The treatment is simply phlebotomize. Treatment is simple. The clinical trial data submitted to the FDA for the approval of AndroGel showed that the use of exogenous testosterone resulted in 9% of subjects experiencing hematocrit levels greater than 56%. Based on AACE guidelines, that number is 54%. If your crit is greater than 54, then you need to phlebotomize or stop the testosterone or lower the dose. This is a level that puts the patient at a serious risk for adverse health consequences and requires immediate treatment or cessation of testosterone therapy. Again, for polycythemia, yes, don't let the blood count, RBC count, hematocrit go above 56% if you have polycythemia. But everyone thinks that erythrocytosis is polycythemia. So if it's greater than 54, go and have them phlebotomize. But I was able to show in court that it was not a risk factor and that they did not need to get phlebotomy. Elevated hematocrit is an independent risk factor for stroke. It absolutely is if the patient has polycythemia. And all those studies to show that an increased hematocrit caused an increased risk of stroke, those patients had polycythemia. They weren't on testosterone. They had polycythemia that caused their strokes and heart attacks. But they've extrapolated that to testosterone erythrocytosis. Elevated hematocrit is an independent risk factor for heart attacks. In another study, 680 males conducted over 28 years in Finland. The data showed that men with hematocrit greater than or equal to 50% were 2.4 times more likely to die from coronary artery disease. Again, those men that died had polycythemia, not erythrocytosis, and they were not on testosterone. In another yet large prospective study, hematocrit level in the upper 20th percentile was found to be associated. Remember what association is? It does not prove causation. Was found to be associated with a 1.5-fold increased risk of venous thromboembolism. An increased level of hematocrit also causes an increase in viscosity of the blood. That's an association. An increase in blood viscosity is a known risk factor for ischemic heart disease. Yes, it is, absolutely, if it's associated with polycythemia vera. This is not polycythemia vera. Show me the study, except the vegan and Finkel study. Show me a study beside the two flawed studies, or randomized controlled trials done in the last 50 years that show that increase in hematocrit with testosterone increases heart attacks and strokes. You can't. I'll show you the studies, all the studies to show that it benefits and protects against it. Now you see the difference. There's a couple studies by Zhu, I think it's XIU. He did a meta-analysis, hand-picked studies where, and they were, again, flawed studies where he showed that there was an increased risk. But when you look at all the well-done randomized controlled trials and the meta-analysis, you don't find it in any study. There's probably been, a dozen studies in the last 2 years that have shown that in men taking testosterone, looking at them long-term, 5, 6, 7, 10 years, there's a decrease in heart attack risk and a decrease in morbidity and mortality. Nevertheless, this is, again, what they claim. They're extrapolating and assuming. An increase in estradiol is in direct relation to the amount of the dose of exogenous testosterone delivered. It is. The higher the dose of testosterone, the higher the total testosterone, the higher the level of serum estradiol. If you use an injectable testosterone and get the level up to 3,000, you'll find that your estradiol level will go up to 200 to 300. When the total testosterone level drops below 200, you'll find that the estradiol level simultaneously, instantaneously, also falls to like 20 or 10. So the estradiol is directly related to the total testosterone, which is why injectable tends to raise estradiol levels much more so than transdermal cream or pellets. There's a twofold increase excess risk of stroke for men that had a serum estradiol level in the top quintile versus in those men that had estradiol levels in the lower. That's absolutely true. We see it in every study in women. We see it in every study in men. This study revealed that estradiol blood levels greater than 34 resulted in this more than doubling the stroke incidence. Absolutely. And in every study, this is a baseline study. These are baseline levels of estradiol that are associated with that increased risk. Where does the estradiol come from in men? Where does the estradiol come from in menopausal women? From visceral fat. It's the visceral fat that produces the estrone that converts back up into the estradiol. The more visceral fat, the more the estrone, the more the estradiol. The thinner the person, the lower the estradiol. The more heavier or obese the patient, the greater the estradiol. It's almost linear. So I would expect high estradiol levels to be associated with an increase in stroke, heart attack, simply because they have dyslipidemia, high visceral fat, high inflammatory cytokines that increase plaque deposition and plaque rupture. It makes perfect sense, but yet we want to blame the estradiol because we measured it and it is high. Association does not prove causation, as in this case, but you'll notice in all of these studies, in every one that they list, they are observational studies. In this study, blood levels of estradiol were measured in 313 men whose average age was 58. Men with higher levels of estradiol suffered a worsening thickening of the carotid artery wall. Of course they did, because they all had dyslipidemia and high inflammatory cytokines. This led researchers to conclude that circulating estradiol is a predictor, it's an association of progression of carotid artery intermediate thickness in middle-aged men. However, I can show you 24 studies where we give testosterone to men that raises estradiol levels and we decrease carotid intermediate thickness. In every study, when we use enough of the testosterone, it will decrease intermediate thickness. Estradiol in women decreases carotid artery intermediate thickness. Testosterone in men decreases carotid artery intermediate thickness. Yeah, but baseline studies show that it increases it. I know. Don't extrapolate baseline high estradiol to be causative of increase in medial thickness. Because when we intervene and do an interventional study and study it and give it, and then we see what the outcome is, in every study, the outcome is a decrease in medial thickness, not an increase as you would predict by looking at baseline studies. In a case control study of men in the Framingham cohort, serum estradiol levels were significantly increased in subjects with coronary artery disease. Well, of course, that's predictive. We don't need to do any more studies. There's 100 studies or more that predict high levels of estradiol in both men and women are harmful, and they portend and predict harm. Don't extrapolate that to what happens when you raise it or give it, because the results are completely the opposite, which is why observational studies, unfortunately, are worthless. A study published in 1995 demonstrated that testosterone treatment was associated with a significant increase in the maximum platelet aggregation response, and this effect may contribute. May does not mean does. May also means may not contribute to the thrombogenicity of androgenic steroids like testosterone. Just because one study showed increase in platelet aggregation back in 1995 does not prove that it does, because all the outcome studies since that time show that it does not. Don't extrapolate or assume. In November 13th, a JAMA study showed that among the cohort who used testosterone, the testosterone therapy raised the risk of death, heart attack, and stroke by 30%. These are the two Vegan and the Finkel studies. Another study in PLOS 1 showed the same thing. Testosterone prescription, not that they took it, we don't even know if they took it or not, but they were given a prescription. I mean, how weak of a study is that? Indicated that testosterone prescription doubled the risk of heart attacks in men. Very extremely flawed studies, unfortunately, but everyone wants to hang their hat on it. Defendants' marketing strategy beginning in 2000 has been to aggressively market and sell their products by misleading potential users and their physicians about the prevalence and symptoms of low testosterone, and by failing to protect users from serious dangers that the defendants knew or should have known about that resulted from use of their products. You can see how misunderstanding this is. What they're claiming harm has been shown to be beneficial in all of the studies. And you can see how and why they claim harm either by two flawed studies or looking at baseline observation. AbbVie's advertising program sought to create the image and belief by consumers that the use of AndroGel was safe and alleviated their symptoms and had few side effects, even though the defendants knew or should have known these to be false. I completely disagree with that, and I show, yes, it does alleviate symptoms. Look at all the studies that we'll look at in the webinar 3, and we'll look at loss of side effects, protection against heart attacks and strokes that they completely ignore. However, I bring up defendants promoted and marketed testosterone replacement for a variety of symptoms caused by normal aging. Well, yeah, why wouldn't you want to treat those symptoms? Erectile dysfunction, loss of libido, loss of strength, energy, athleticism, loss of muscle mass, fatigue, mood swings. Why would you not want to treat those things? Well, because those are things you get with normal aging. Well, yeah, of course you get it with normal aging, but that doesn't mean you shouldn't treat them. However, the drug was never FDA approved for these uses, and probably will never be. Defendants purposely downplayed and understated and outright ignored the health hazards and risk. I still do not see the health risk. When you look at it logically, there's not only no health risk, but there's only health benefits. And they downplayed the adverse and serious health effects. Every risk and health effect that they've stated is from a flawed study or from an extrapolation of a high hemoglobin and high estradiol. Defendants concealed and minimized user and prescriber concern regarding the safety of AndroGel. including but not limited to its propensity to drastically raise hematocrit and estradiol in users. You can see how they want to hang their hat on the increase in hematocrit and an increase in estradiol causing harm. I proved successfully in many cases high hematocrit does not cause harm, and high estradiol is actually beneficial and not harmful. Defendants failed to mention any potential risk of cardiac events, strokes, pulmonary embolism, or dangerous side effects related to blood clotting. They did not warn. Defendants also failed to warn and instruct. Therefore, I'm advising you to warn and instruct in your consent as well as in your notes. You've advised the patient of the FDA warnings that are listed in the PDR. You can state that you disagree with it, but if the worst thing happens and you get struck by lightning and have to end up defending it, did you warn them? Yes. Where does it say it? Right there in my note and in my consent. I warned them and instructed them. They cannot tell you that you did not warn and instruct. You warn and instruct, the patient accepts these risks and agrees to the use of testosterone. AndroGel's prescribing information and medication guide contained within the packaged materials do not warn against stroke, pulmonary embolism, transient ischemic attack, cardiovascular disease, myocardial infarction, or thromboembolic events. Well, now the PDR does. Now the package insert does. Back then it did not. So if you want to copy the package insert and give it to the patient, you can. But I also advise the reason we're giving it to them is to warn them because that's standard operating procedure. However, we completely disagree with the warning, and you have to understand why the warning is there. Because somebody reported it to the FDA. If it's reported to the FDA's responsibility is to include it as a warning in the PDR or the package insert. That's why it is done. It doesn't mean that it causes it. It doesn't mean that it produces it. But you've warned them. That's the FDA's responsibility. That's your responsibility too. It'll keep you out of trouble. Their materials fail to instruct patients to tell their health care provider that if their underlying inherited trait increases the risk of blood clotting, like factor V Leiden, or any prothrombin gene mutation, that they need to advise the healthcare provider or doctor. They also fail to instruct patients or physicians to be aware of the presence of comorbid conditions or pre-existing heart disease, for which has been proven to double the risk in men under age 65 that use testosterone. A recent study came out and showed that testosterone is extremely safe in patients with heart disease. In fact, is recommended in patients with heart disease. That's a randomized controlled trial. But yet, this here is not. It's an observational study. Randomized controlled trials not only say that it is safe, but recommend it. Prescribing information and medication guide do not instruct physicians or patients that it can increase red blood cell count to the point that it more than doubles the risk of stroke, pulmonary embolism, ischemic heart disease, heart failure, and myocardial infarction. Testosterone does not do that. Well, high hematocrit does. Yes, it does if it's associated with polycythemia. It does not if it's associated with the physiologic erythrocytosis from testosterone or living at altitude. The increase in serum estradiol caused by the drug can interact with underlying clotting trait to produce blood clots in the legs and lungs. That's a WTF statement. How does estradiol in the serum interact with underlying clotting trait? Please prove that one. Explain that one to me. Well, if you give Premarin to patients with factor V Leiden, it causes blood clots. Don't extrapolate and don't assume. What are you thinking? Patients with estradiol that they normally produce on their own does not increase the blood clot rate. The ESTRA trial and other studies show that transdermal estradiol does not increase blood clot risk in patients that have factor V Leiden, prothrombin mutation, or any of the congenital thrombophilias. Well, oral Premarin, don't extract oral Premarin with increase in serum levels by giving testosterone or by giving transdermal estradiol. They also fail to instruct physicians to screen all patients for underlying clotting traits before prescribing testosterone replacement. Do we test for underlying clotting traits before we give birth control pills? No. What about oral estrogen? No. Why? Because it's not financially beneficial, because the rate of return and benefit does not outweigh the cost of doing so. Well, if we don't do it for women that take oral birth control pills or oral estrogen, then why do we need to do it for testosterone? Well, because GluX suggests it. That's one person. Why is it only one person that wrote these studies? Why is there only one person that is a zealot for this? Why is there only one person that suggests this? I don't know. Is it suggested by any other researcher? No. By any other study? No. Is it suggested in the PDR? No. Why? Because we do not see that. But yet, that's what they will claim because they're trying to make an association into causation, which they should not do. There's no warnings that blood clots in veins are a consequence of polycythemia could result in pulmonary embolism. It's not polycythemia. It's erythrocytosis. No, it's the same thing. No, it's not the same thing. If you think it's the same thing, the conversation cannot go forward. Unfortunately, I can show you 100 studies in the literature that show that testosterone causes polycythemia. It's a universal term for an increase in hemoglobin hematocrit. But they extrapolate poly to physiologic erythrocytosis. They should not do that. There's many studies that actually show that. If you go on that YouTube video, I explain those studies to show that polycythemia is not erythrocytosis. It does not result in pulmonary embolism. Polycythemia does. Erythrocytosis does not. The prescribing information and medication guide contained with the package materials fail to warn that the use of testosterone resulted in elevated levels of estradiol. They do not instruct physicians to monitor estradiol levels, nor do they provide any guidance to physicians or patients regarding the significant health risk associated with elevated levels of estradiol. What health risk? Including the fact that there's a twofold excess risk of stroke for men who had estradiol levels in the top quintile. Yes, they did. I don't disagree with the study. But what I disagree with is that's an observation, and you're extrapolating an observation to prove causation. But in every study, when we raise it by giving testosterone or raise it by giving estradiol, we do not see that. There's a multitude of different studies where we gave estradiol to men with prostate cancer. No increased risk of DVT, PE, heart attacks, or strokes, either with transdermal estradiol or with oral estradiol. In fact, there was benefit and protection. All men that are on Casodex and Lupron should be on estradiol. They state here, oh no, you don't want that. Yeah, but when you don't give it, there's an increased risk of heart attacks and strokes, and the studies show that when you're on Casodex and Lupron and take estradiol, it protects against the heart attacks and strokes that you get when you wipe out estradiol levels. Wiping out estradiol level is going to cause harm. They're claiming, no, you need to lower the estradiol level because they do not understand an association does not prove causation. The prescribing information and medication guide contained within the package materials do not warn that the use of the product may result in the formation of DVTs, pulmonary emboli, stroke, infarction, heart failure, cardiac disease, all caused by elevated levels of estradiol. I have to laugh because, you know, there are people out there that thoroughly, truly believe that. They completely, thoroughly, absolutely believe that statement because they have no clue or understanding of observation versus causation. And they do not understand all the studies showing that raising estradiol by giving testosterone or by giving estradiol protects against DVT, pulmonary embolism, stroke, infarctions, etc. We'll look at that in webinar 3. The prescribing information and medication guide contained within the package materials do not offer any warning of the various serious health risks for men over the age of 65 who use testosterone replacement therapy. I'm sorry, I don't know of any randomized controlled trial that shows harm in men over 65 that take testosterone. And please don't say the vegan Finkel study. Those are not randomized controlled trials. It's purely observation, which are extremely weak and flawed. The FDA added additional warnings to testosterone products. In 2014, they added these risks of DVTs and PEs because of the report to them that someone reported in their study that they saw it. It doesn't mean it causes it if every study shows that it does not cause it. But the FDA required this change in drug labeling to reflect that, and that's why it's listed in the PDR. Just because it's listed in the PDR doesn't mean that it causes it. It says that it may. As a result of this mandate by the FDA, on June 2014, the defendants updated the prescribing information to provide the general warning required by the FDA regarding DVT and PE. But you understand why the FDA did that. Because it was reported to them. And as a result of reporting it to them, AbbVie and Abbott now listed as a warning. And when you look at that, it'll say it as a warning. It may. But you have to understand why they included it and why the FDA includes it, just because one man reported it. The prescribing information and medication guide contained with the package material still lacks any warning about the risk of estradiol levels. It now talks about the risk of hemoglobin hematocrit and the risk of strokes and heart attacks, but it does not list or describe the risk of elevated estradiol levels. I would love to defend this case. I dream about defending this case. I'm not an academician. I don't have academic credentials. I've done none research. I'm not published. And therefore, I will probably never defend this case. But you can see my logic in defending this case. I hope that their experts will understand my understanding. However, most experts do not understand my understanding, and I don't understand why they don't understand it. It's relatively simple to understand. If I can understand it, it's simple. What I don't understand is how they don't understand. They don't understand because they assume and extrapolate baseline to being causative. Coming down to the end. If plaintiff and his physician had known the risk and dangers associated with testosterone, the physician would not have prescribed it, nor would the plaintiff have taken it. Consequently, he would not have been subject to its serious side effects. And plaintiff's physicians would have adequately monitored platelets, hematocrit, and estradiol levels, and the plaintiff's injuries would not have otherwise occurred. I completely disagree with that, but now you see where they're going and why. Abbott and AbbVie had a duty to warn prescribing physicians about the risk of AndroGel use, and they didn't. Because of the use of AndroGel, plaintiff suffered a heart attack, stroke, and DVT, and continues to suffer from cardiovascular disease, loss of life's pleasures, fear and fright, embarrassment, humiliation, economic loss, etc., etc., etc. I haven't gotten to the good part yet. We'll get to that as the last sentence. Cause of action. Plaintiff was unaware of any connection between his use of testosterone and heart attack, stroke, and DVT. And as a result, AbbVie and Abbott did not warn the patient. And you can see how this will get you into trouble too. You failed to warn the patient. Warn them. Document it in your note, document it in your consent, and you can even copy the patient handout. The AndroGel manufacturer was supplied defendants with a defective warning, and they failed to adequately warn consumers about the health risk. And defendants failed to adequately warn consumers that it could cause heart attacks, strokes, pulmonary embolism, or cardiac events or clots. Well, you can warn them that it may. It doesn't cause it. It may, and that's what it states. It's necessary to frequently monitor hematocrit and estradiol levels. I completely disagree with that. I do not monitor hematocrit and estradiol levels. However, if the PMD says the hematocrit is high, I phlebotomize the patient. I don't argue with the PMD anymore. I don't argue with the patient. Just do it. Let them go spend the $200 and get phlebotomized every 3 months. If they do not have a PMD, I do not phlebotomize. I've adequately defended that in court. Defendants had a duty to properly manufacture, compound, test, produce, distribute, package, prescribe, and warn of the risk of AndroGel. Since you out there prescribe, then you need to adequately warn. Then you're covered. That's what I would recommend. Defendants sought to mislead and misinform physicians concerning the uses. Take it off your websites. Do not make claims for testosterone. Defendants recklessly, intentionally, and knowingly detailed and promoted testosterone with the intent that men be prescribed testosterone by physicians for off-label clinical indications. It is not illegal to do so. It is illegal to market it and advertise it for such. Don't do it. Defendants knew there were safer alternatives and methods to treat loss of energy. Please explain to me what alternative there is to treating loss of energy. Loss of libido, there's only one thing that helps improve libido, and that's testosterone. What's the alternative method to treat erectile dysfunction and loss of energy? And depression in men, loss of muscle mass. There's only one thing that helps improve muscle mass. Again, I completely disagree with that. Low T is not a recognized medical condition. I believe it is. I don't know how they can say that it is not. But what they can say is it's not FDA approved to treat that medical condition. And I agree with that. Don't do it. Defendants knew that the product would cause an increase in hematocrit and estradiol, and they didn't advise. I disagree with that, but advise them anyway. Defendants knew that testosterone is not safe and fit for human consumption. I completely disagree with that. And it's hazardous to your health. I disagree with that. And has a propensity to cause serious injury. I completely disagree with that. And I've proven that before. There's no approval by the FDA to warrant promotion of these indications for clinical use. I agree with that. Don't do it. It's simple. You'd like to, don't. Don't advertise it for off-label use. Everyone prescribes it for off-label use. Document it's for off-label use. Put it in your consent and in your note that it's for off-label use, and tell the patient it's for off-label use. Have you told them it's for off-label use? Yes. Should you? Yes. Those are sort of standard operating procedures that you tell the patient is for off-label use. What about other medicines? Do we tell other patients about off-label use of any other medication? No, we don't. For testosterone, do it. It'll save you a lot of time and headache if lightning strikes you. There is negligent misrepresentation. I've been through that already. Just advise them what the PDR says, and then you will be covered. The acts, conduct, and omission by the defendants, as is alleged throughout this complaint, were willful and malicious. You're kidding me, right? Nope, that's what they say. Defendants' outrageous and unconscionable conduct, yes, that disgusts me as much as it disgusts you, warrants an award of exemplary and punitive damages against the defendants in an amount appropriate to punish and make an example of defendants. That's what I wanted you to see. If that's not a punch in the stomach, I don't know what is. I told you there's a war. This is the war. Finally, defendant's conduct was despicable and so contemptible that it would be looked upon and despised by ordinary, decent people. There is willful and conscious disregard for the safety of plaintiff and the public, entitling plaintiff to exemplary damages. Here's the clincher. Plaintiff prays for judgment against the defendants. Okay, I hope that was all good news to everyone, but I hope that you understand what's going on, what the war is, what the battle is, how to defend, how to protect yourself, and what to do. It's probably going to take years of reversing this until we finally come up with all of these cases that when we win to prove that no, hematocrit is not causing heart attacks and strokes, estradiol is not causing it, and that hopefully we'll be able to advertise and advise the patients of the benefits of testosterone and not have to scare them away. Okay, I know I went over, but it was an important webinar to know and understand. Let's do questions and answers.
Neal, can I interrupt for a minute? For those of you who just joined us, if you'll look in the lower right-hand corner of your screen, you should see the question and answer box where you can enter your questions to Neal. Thank you.
Kim Hansen asked, are you able to share the slides of this presentation for future reference? If you'll contact Dana at WorldLink, and then she can help you with that. Mary Riley asked, is the information regarding estradiol blocking an orgasm true for women as well as it is for men? No, it's not. Testosterone has to do with orgasmic ability in women. It's actually testosterone as well as estradiol that has to do it in men. Now, let me explain that. If you give just estradiol to men, it will lower their testosterone levels and adversely affect libido, sexual function, and orgasm. However, when you give testosterone and block estradiol, that's completely different. When you give testosterone to men and block estradiol, it will adversely affect orgasm and sexual function. When you raise the estradiol, it reverses it and brings it back up to normal. So don't give just estrogen to men. It'll block their testosterone, which is not what we want to do. But when you give testosterone, which raises estradiol, don't block the estradiol. It will adversely affect orgasm in men, but not in women. Kim Hansen writes, the lawsuit is certainly dangerous. If they are successful, it will set a very dangerous precedent for all practitioners. Well, yeah, I know, which is sort of why I would love to defend the case, but I've not been asked to, and I explain the reasons why I've not been asked to. But I just sort of want you to know that, yes, there is a war. You may not know of the war. It's very unsettling, which is why I think it sets a precedence to win this case. And, of course, I've set precedent by winning other cases, but that does not mean that other cases will still not be filed. Rob says, I have 26 with either FAV versus or FACT 2 on therapy with no thrombotic events. Oh, I see. Rob's got 26 patients that have factor V Leiden or prothrombin mutation 2 that are on therapy with no thromboembolic event. Well, Rob, you should publish that. Unfortunately, it does not prove causation or protection. It's just an observation. But I agree with you, and that's what I found too, that I've got patients on testosterone. They have not had any events, which we can then claim protection, and that should be a direct rebuttal in response to GLUX study. But somebody will come along and criticize us because it's flawed, it's just an observation, it does not mean anything, but yes, you can prove and show that our observation is meaningless, his observation is also meaningless. Rob, your point is well taken. Thank you, and thank you for sending me that information on what's happening in Ohio. Kim writes, even if Abbott is guilty of false advertising claims, this whole case will be used as a precedent that we are recklessly prescribing testosterone. Not recklessly prescribing it. You can prescribe it, but don't recklessly promote it on your websites because it is not FDA approved for what you are promoting it for. That's what you have to be careful of. You can prescribe it all you want. There's no criticism to you prescribing it. There's no law or restriction against prescribing it. You're just not prescribing it for the FDA approved indication, which is very restricted. But you can prescribe beyond the FDA approved indication, which is off-label use. It's perfectly legal to do so. Chris writes, regarding off-label use, does this allow us to use testosterone injectable for regenerative injection therapy, prolotherapy, as Dr. Debunked has studied, and it has a prospective study on this. Yeah, sure. It allows you to prescribe it for any indication that's legitimate. And by that, I mean if you have scientific studies to show that, and this is in peer-reviewed journals, that there's a benefit to it, and you're prescribing it for that benefit that's listed in the studies, you can very legally prescribe it. And if you want to use it and prescribe it for helping to improve symptoms, then yes, you absolutely can. It is very legal for you to do so. Just document why you're doing it. Mike writes, can you bill insurance for the off-label use of low testosterone? You can. Remember what it means when I say I can? It means you can, but I don't. You can. But if insurance denies it, then you'll understand why. Most insurances will deny it. You have to send into the insurance company 2 lab tests done a week apart that show that early morning 8 a.m. testosterone levels are less than 300. If you do not have that and associated symptoms of hypogonadism, then they do not qualify for a diagnosis of hypogonadism, and they do not qualify for treatment based on FDA guidelines. And insurance is only going to cover it for FDA-approved treatment. You're not prescribing it for an FDA-approved treatment. You're prescribing it for off-label use. It's the insurance company's right to reject that prescription as it doesn't fall under FDA guidelines. You can submit it, but they don't have to pay it. I don't fall into that trap. I don't submit it anymore to insurance. When the patient says, no, I want to submit it to insurance, I say, you need to go see somebody else. Yeah, but I want my insurance to cover it. Good. Go see a nice urologist and have them test you. Well, then I don't qualify. You're right. Well, I still want you to submit it. No, I don't submit it, and I'm not going to do what you want me to do. If you want me to prescribe it, I will. If you want me to submit it to insurance and have to fill out all the forms and document that you fall under the guidelines for which they will prescribe it or for which they will cover it, then I don't do that. You need to go see somebody else, but yes, you can. I don't. Dr. Chillian asks, what clotting coagulation profiles do you obtain prior to initiating testosterone? I do not do any clotting or coagulation profiles. It is not recommended in any FDA PDR handout on testosterone. It is not accepted to do it. It is recommended by GLUEC, but that's one person. Just because one person recommends it doesn't mean that you do it. I don't do it, but you can do it. You could do a thrombophilia workup. It's cost prohibitive. Here is the bio on the Georgetown expert. Teaches herbal gardening, etc. Okay. Robert Driver asks, what is your opinion about marketing material that only references BHRT, not a specific medication, as in bioidentical hormone replacement therapy, may improve symptoms of X, Y, and Z? If you say may, that means it will. You are misleading the public. You are misleading a patient that the therapy that you're going to prescribe for them will improve symptoms or a disease or an illness. You can state, well, maybe there was a study. In this study here, they showed that estrogen improves blank. In this study here, testosterone improves sexual function and libido. You can mention the study, and you can mention that what the results of the study was, but you again still have to be careful, because if you infer or you assume, then you're still being guilty. You can only list, if you want to be perfectly clean, you can list the symptoms of low hormones. You can list the FDA approval for those hormones, and you can list that you prescribe those hormones, but you cannot make claim that it treats or improves symptoms of X, Y, or Z. You can, I don't. I don't suggest it. I know you want to. Is bioidentical HRT FDA approved? No. Well, is bioidentical estradiol FDA approved? Yes. What's it FDA approved for? Treating menopause. What is progesterone approved for? Preventing endometrial hyperplasia. What is testosterone approved for? Treating hypogonadism. What about symptoms? It does not say the bioidentical estradiol, progesterone, or testosterone are FDA approved to treat symptoms. It only states what it has FDA approval for, and you should not go beyond that, because if you do, then you are suggesting and misleading a patient to believe that it does. And that's the key, is the FDA, and I've seen these cases and I've had to deal with it. These cases are, you're misleading the patient. You're making the patient believe based on what you stated. Even though you did not state it specifically, you made the patient assume, or you've misled them. So I strongly advise you, don't mislead the patient or put anything on there where it might or may infer treatment of a symptom or medical condition. Chris asks, what about iron replacement around phlebotomy? The protocol for this? I don't know quite what your question is. Your question is, how often do you phlebotomize somebody? Every 3 months. What about iron replacement? We'll measure iron levels and then give oral iron. If you're going to phlebotomize somebody, and I had a Cenegenics physician come to me with an extreme fatigue, and they got phlebotomized every 2 months to treat his polycythemia. His iron level was 5, his ferritin level was 5, he was extremely iron depleted. I gave him IV Venifer. He felt tremendous, back to normal, saw him again in a year, still fatigued. Measured his iron level, still low. I said, why is your iron level still low? Are you taking iron? He says, well, no. I said, are you still phlebotomizing? Well, yeah, I got to keep my hemoglobin hematocrit down. I go, you got to be kidding me. He goes, no, I got to prevent the polycythemia because it causes strokes and heart attacks. He completely did not understand or hear what I had to say. So I said, well, I think you need to go see somebody else. You can take oral iron if you want to. Keep an eye on the iron if you phlebotomize all the time. The phlebotomy should be whenever your hematocrit goes above 54, then you get phlebotomized. Those are based on guidelines from the Hematology Academy, and the American Academy of Endocrinology took their guidelines from the Hematology Academy, whereby you should phlebotomize somebody with a hematocrit 55 or greater. 54 or less is okay, then you monitor it. If it goes above 54, then you treat. That's the protocol. Hi, George. George Andreoff asked, is there a template that I can use to be sure my website and consent forms are correct? No. George, in the last course, I said that I was going to be handing out a information sheet on testosterone. I'm now having attorneys look at that to make sure that it is okay, and hopefully within the next month or two, I can get the blessing of the attorneys. But if you want, if you didn't get that last handout, contact Dana, and she can send it to you. George and I used to be old roommates. What memories we had. I wish I could tell you those memories, but this is a family lecture. Chris asks, do you test for the MTHFR gene, homocysteine, for increase in clotting ability? I don't, but you can. That's included in the thrombophilia or clotting workup. You can test that, and of course you would then give an absorbable B12 and folate to help treat that. Yes, you can, but I don't routinely test it unless patients have symptoms. Kim asks, when is webinar number 3? I don't know. You have to ask Dana. Maybe Dana or Mary have an idea as to when that is. I think that they told me, but I can't remember where it is. Maybe you can tell us before that's over with. When is it, Mary?
Second Tuesday of the month, March 14th.
March 14th is number 3 then. So you got 1 and 2, and then March 14th is number 3. Holly asks, what about replacing testosterone in women who have previously had oral contraceptive-associated DVTs? I do not find anywhere in the literature where testosterone shows an increase in DVTs or PEs in women. So I don't think there's any specific protocol. I don't see that there's any warnings, but unfortunately, testosterone is not FDA approved in women, so you're prescribing it for off-label use. But I do not find any circumstance where it would be associated with an increased risk. So let me extrapolate the question. What if a patient has a DVT from taking oral contraceptives or oral estrogen? Is transdermal estradiol safe? Yes, in every study. The Estradiol and every other study shows that even in patients with congenital thrombophilias or prior DVTs, taking transdermal estradiol does not increase the risk in any study, nor does oral progesterone increase the risk in any study. And I have not seen any study, and there's a multitude of studies, where transdermal testosterone increases any risk either. It's the oral estrogen that increases clotting factors through first-pass effect. Nothing else increases clotting factors. Progesterone or testosterone do not increase clotting factors. Janet asked, do you monitor the levels through saliva or blood? I never monitor it through saliva. I only monitor it through blood. Saliva levels are going to be extremely high. You can have extremely low levels in the blood. So with any transdermal preparation, you'll see extremely high levels in the saliva, extremely low levels in the blood, which is why I don't rely on saliva for testing transdermal preparations. Kayla asked, do you have a testosterone consent form you can provide us? I don't. I just have a regular consent form to make sure that everything is written correctly. I just have a regular consent form that I prescribe hormones for off-label use, and there's no guarantees. That consent form is given in the Part 1 lecture under medical forms. I don't use anything differently. Hi, Jeff. Jeff asked, besides testosterone, what other hormone replacement have you seen that have led to court cases? I've never seen thyroid go to court. I've seen thyroid go to medical boards, and it's your peers that scream and yell that you prescribe thyroid. And then they don't like you prescribing thyroid because they don't understand why you prescribe thyroid, because the TSH was normal. You can prescribe thyroid for off-label use. The experts say that you shouldn't, the patient should not have been prescribed thyroid because the TSH level was normal. Well, it is normal in almost everyone. That doesn't mean you can't prescribe it for off-label use. And you know, Part 1 is a 3-hour lecture on thyroid. Part 2 is a 2-hour lecture on thyroid. Part 3 is a 2-hour lecture, and Part 4 is a 2-hour lecture on thyroid. And it's not treating hypothyroidism with elevated TSH, but those are the only indications as by the experts. However, that doesn't mean you can't prescribe it for off-label use and to improve symptoms. Never seen it go to court. I've had to defend it in front of the medical boards, and once I educate the medical boards that the medical literature supports the use of it to treat symptoms, you can't deny it. They're peer-reviewed articles on showing how thyroid replacement helps improve symptoms, etc. Dr. German, hope everything is well up there on the Monterey Peninsula. Can I provide a template for a consent form? Richard, you were given the consent form in the Part 1 course. Go back to the Part 1 syllabus. It's in the Part 1 syllabus, the consent that I use. The information that Neal is presenting for the use of testosterone is confusing the heck out of me. I'm sorry. In Part 1, he stated that is approved for andropause, but not for symptoms. Yes, it is FDA approved to treat hypogonadism. It's not FDA approved to treat symptoms. Now I hear it's approved for treating hypogonadism, but if it is from a congenital cause of hypogonadism, yes, under recent FDA guidelines, testosterone is FDA approved for use of hypogonadism, which is defined as a medical condition that results in low testosterone production and to test with your total testosterone levels of less than 300. That's how hypogonadism is defined. That's what it's FDA approved for. I don't think I've ever seen a patient with hypogonadism. I don't think I've ever seen anyone with any congenital cause. So everyone that I treat is off-label for symptoms. It is not approved for off-label use. That is true. No medicine is approved for off-label use. It doesn't mean you can't use it for off-label use. Don't advertise it for off-label use. And if you use it for off-label use, document why you're using it. But we cannot mention the symptoms. You can mention the symptoms to the patient. You just can't mention the symptoms when you advertise it on the internet. I'm confused beyond what was in the conference. What's in the conference is all the medical studies that show that testosterone is beneficial for a treatment of a multitude of medical problems, conditions, illnesses, and symptoms. It's not FDA approved for that. But the literature shows that you can do that. Just you cannot advertise that. You can understand why we use it. You can tell the patient why you use it. You just can't advertise it on the internet in any of your advertising materials, period. Sorry, I hope that's not confusing. Dr. Vora asks, it's unclear to me who gains from the war against testosterone. What's motivating the zealots? I see no financial or other gain from them. Oh, you don't understand politics and economics, and you don't understand control. Who's being spanked? The drug companies are being spanked by the FDA for marketing for unapproved use. They're marketing for off-label use. You cannot and should not do that based on consumer protection. And as a result, they're getting spanked. In addition, plaintiffs' attorneys are now bringing suit against the companies as well as against doctors that prescribe it to try to get money. So they've upset the FDA, who's trying to regain control and spank them. Plaintiffs' attorneys are trying to get rich off of patients that have had unfortunate heart attacks, strokes, DVTs, based on that's just a natural occurrence, but they got to blame it on something. If something bad happens to somebody, it's got to be somebody else's fault. So there is financial gain to the plaintiff's attorneys. There's no financial gain to the FDA, but there is gain based on control, and that's what they're trying to do. I know that makes no sense, but I can't explain it any better. Do you have an example of a consent form that we can share? The consent form is in the Part 1 syllabus. Rob says, I met with Gluek, and he was somewhat flabbergasted and did not want to continue to explore my data. Rob, why did you do that? I mean, don't teach a pig to sing. It just thoroughly pisses off the pig and it frustrates you. I don't know why you would go to Gluek, who's trying to show and prove that you shouldn't use testosterone unless it's for approved indications and that it causes blood clots. And as a result, you shouldn't use it. I mean, that's pretty much what he's trying to say and state and claim. And then you go and try to prove him wrong. You try to go against what he's trying to say. You're trying to change his religion. And you're not going to get anywhere by doing that. So don't even try. But anyway, nice try. I understand what you've tried to do. And I can see your face and your wonderful smile looking back at him going, you just don't get it. Do I have any pearls on how to address the use of compounded hormones on your consent forms? Yeah, I do. We prescribe compounded hormones which are not FDA approved to treat any disease or an illness. We don't make any guarantees as to what we do or how we do it, but we're using hormones for off-label use. That's pretty much what the consent says in the Part 1 syllabus. Lane, hi Lane, says the whole basis for a misunderstanding is much of what we do is flawed interpretation of the literature. I guess that's what I was trying to say. I guess I just didn't say that. Thank you for making it so clear. Yeah, exactly. And that's why we'll do the Part 3 and the Part 4 webinars, is to go through that medical literature and studies to show and prove that what all these experts are stating and claiming is not true. It's completely incorrect. And it's a flawed interpretation of those two studies, yes. And it's complete ignorance or ignoring all of the other medical literature. You know, we got another study that just showed the same thing. 600 patients were studied. Those that took testosterone, no heart attacks, no deaths. Those who didn't take it, over 20 deaths from heart attacks. What does that mean? Well, it means that testosterone causes heart attacks and strokes because it increases hemoglobin, hematocrit, and estradiol, right? No, it's just the opposite. When you increase estradiol and hemoglobin, hematocrit, we don't see it. There is no harm to it, but yet they will extrapolate and assume because they do not understand, and yes, they absolutely misinterpret. That's so sort of what's so fun is that it's sad, but it's fun that so many relatively intelligent people completely do not understand and misinterpret it. They don't get it. Are physicians not required to take statistical analysis in their training? No, we're not. Are we required to think logical? No. Lane, you misunderstand this. Do they really not understand observation versus causation? They absolutely do not. They absolutely have no clue or concept to what it is, and they do not understand it, number one, to their benefit, but they thoroughly don't understand it. You know, I can go to AMMG, I can go to A4M, and I can lecture and give a whole hour lecture on observation versus causation and the fact that estradiol is beneficial in men when you study it, when you give it, and it's completely harmful in men when you measure it baseline. And I absolutely show the 20 studies to show that it's harmful when you lower it. The next 20 lecturers will get up on a podium and explain the harm of estrogen and the need to block it and lower it. They completely do not get what I said. They completely do not understand the literature. They completely ignore all the studies showing benefit when you raise it and harm when you lower it. They just don't get it. They don't get it because they don't understand observation does not prove causation, and all they look at, well, in these 100 studies, we observed that high levels are high, and they just don't get it. I'm sorry they don't get it, but that's, they don't get it. Scott asked if you cannot state that testosterone can improve erectile dysfunction, sense of well-being, muscle mass, then what can you prescribe it for? You can prescribe it for erectile dysfunction and loss of libido, loss of orgasmic ability, poor sense of well-being, depression, mood swings. You can prescribe it for loss of muscle mass. You can prescribe it for anything that you want, but you cannot market it as such. Then what can you prescribe it for? You can prescribe it for all of those things that the medical studies have shown that it's beneficial. You can prescribe it for low levels. You can prescribe it to help improve symptoms and quality of life. You can prescribe it for all that. You just cannot market it for such. That's the point. Hi, Dr. Kadambi. How are you, Shook? As everyone knows has taken the courses, Dr. Kadambi is one of our esteemed endocrinologists that has taken the course and understands how to do things. Here is an endocrinologist that understands it, Lane. What can I say? Can we start testosterone right after surgery for prostate cancer? Of course, Ashok. You can start it right after surgery for prostate cancer. You don't need to wait a year. There's no evidence-based medicine that says when you can or cannot start it. All you know is that all you do is follow the PSAs. If the PSA starts to go up a time, then you need to go back and reevaluate that maybe you need to do some other definitive treatment. But if you've had surgery or radiation or brachytherapy, then you can start it anytime you want. The consultants will say stop the testosterone until your PSA falls to less than 0.1. That's fine to do. That's okay to do. And I tell the patient, you know, you can stop it if that's what the consultant says. If it was me or you, we wouldn't stop it. I'm not going to stop my testosterone. I'm going to continue to take it. Why would you want to stop it? You'll lose you lose your well-being. You'll feel lousy. Well, doesn't it cause the cancer to grow? No. We looked at Part 3 and Part 4. Testosterone administration does not cause cancer to grow, and that's based on the saturation model that was originally introduced by Dr. Morgenthaler and has been since proved by many other researchers. If your level is less than 200, sure, it may cause the tumor to be stimulated, but above a level of 200, putting more testosterone in the system does not cause it to grow any more than a level of 200. So it really doesn't make any difference if you stop it or continue it. You're not going to stimulate the tumor to grow. by giving them testosterone if your baseline level is greater than 200 to begin with. And as you and I know, Ashok, it makes no sense to treat our parents by taking testosterone away from them when they will feel so much better on it, and it does not cause any adverse effect. Amy says, is Dr. Morgentaler involved in defending this case? Yes, he is. This goes against the expert consensus he was involved in. Yeah, I know. I don't want to get into that. But yeah, that's my concern. A lot of the experts that are probably defending the case maybe not know or understand estradiol or hemoglobin hematocrit. And of course, he's involved with all of this research and showing how beneficial testosterone is. He will have a great input into this case. I would love to go and listen to the experts testify in this case. I haven't spoken to Abe about it because he cannot discuss the case with anyone. Richard German says, I avoided the insurance problem by giving the patient a letter that states my diagnosis, recommendation, and treatment and cost, and let the patient do all the footwork. It occasionally works. Yeah, it occasionally works where the patient is able to hand in their receipt to the insurance company and get reimbursed, but more and more, now that we see the FDA strict diagnosis guidelines and that the insurance companies are reimbursing only for the patient that falls into that strict reimbursement guidelines, you will waste your time, effort, and energy filling out all this paperwork and sending it back and forth, back and forth, back and forth. It's a no-win situation. So yeah, you can give them the receipt. We used to do that. But then when they sent it in and the insurance company said, we want all this documentation, all these forms filled out, these lab tests, et cetera, and basically was a energy loss to us, so we no longer do it. Dr. Syed, how are you? States testosterone placement in women with breast cancer. That was in part 2 motion where testosterone is used to treat and protect against breast cancer in women. Rebecca Glasser has published her most recent studies in Maturitas, the European Journal of OBGYN, and she has taken the recurrence of breast cancer from an average of 350 per 10,000 down to around 50 or less per 10,000 by treating with testosterone. And the levels that she achieves in her study is a level of total testosterone around 300 to 400 that she has been shown to be protective. So I recommend and I tell all patients that the best way to protect against the most common cancer in women, which is breast cancer, is by optimizing testosterone and certainly optimizing progesterone. That's all discussed and demonstrated in part 2. Dr. German asks again, can I advertise on my website the typical symptoms associated with the aging process, libido, hot flashes, those things? Yes, you can advertise the symptoms of loss of estrogen, progesterone, and testosterone. You can show the symptoms of loss. What you cannot make the leap to is that your treatment reverses or treats those symptoms. You can state loss of estrogen, progesterone, testosterone, thyroid cause these symptoms, and an increase in heart disease, strokes, heart attacks, bone loss, etc. You can state what happens when you lose it, but you cannot make the statement that your treatment treats those things or reverses that. You can state that estrogen, progesterone, and testosterone have been FDA approved to treat certain things, and that's all the further I would go, other than also saying that we prescribe bioidentical hormones in our clinic. You can state that you can prescribe bioidentical hormones, you can state hormone deficiency, but you cannot make that leap or state that your treatment with bioidentical hormone helps to improve those symptoms. I know you'd like to, you can't, you should not. You can, I don't. I suggest also that you don't. So, yes, you can document the symptoms of a loss, but don't demonstrate that your treatment reverses those symptoms or treats those problems. Dr. Fitch asks, will we be able to listen to this recorded webinar later? Yes, absolutely. All you need to, if you were originally registered for the course, I believe Mary and Dana have said you can go back in a later time, go to webinars, click on it, and then you can listen to it again. So for those people that were not able to hear this live recording, you can go back in at a later time and hear it. Kim Hansen says, hope that you are doing well. I am, thank you. It's a long story, but I am doing better. Thank you very much. I'm going to get my stem cells from Dr. Pang probably next week. So I'm really looking forward to that. See you in August to start the series all over again. Thank you for doing what I do. Thank you for thanking me. Yes, I do change the course each time, and Dana is busy sort of revamping each one of the courses. I'm putting in new data, taking out old data, old studies, putting in new ones, redoing the slides, and sort of redoing the courses. So by August, you'll see all new part 1, 2, 3, and 4 in comparison with what you've had before. And thank you, Kim, for your well wishes. Okay, I think that ends our webinar. Thank you very much for listening and attending. Look forward to seeing you in webinar number 2. Thank you and happy Valentine's Day.
Thank you, Dr. Rouzier. I hope our listeners enjoyed it as much as I did. Our next webinar will feature part 2 of this topic with Dr. Rouzier and is scheduled for February 21st. Happy Valentine's Day, everyone, and thank you again, Dr. Rouzier, and everyone who joined us today. Have a wonderful rest of your day.